Okay, you can start.
Sir, can I start? So, 58 years old male came with complaints of hematuria since 2 months.
I would like to know what is the type of hematuria and the number of episodes, whether it's a painless or painful type of hematuria, and whether it's associated with clots.
Harish, a little closer to your mic, please.
Yes, sir. So I would like to know what is the number of episodes of hematuria, whether it was painful or painless, or whether what's the type, initial, terminal, or total hematuria, and whether it's if it is associated with the clots, what are the type of clots, whether it was amorphous or serpentine type of clots, and whether it's a self-limiting.
Why do you want to know the number of episodes?
So it gives the what is the intensity of hematuria, sir?
That doesn't add any value, isn't it?
Yes, sir.
He said hematuria since 2 months, so there have been a few episodes. On the other hand, the other things carry weightage. So in the exam also, leave out the unnecessary questions.
Yes, sir.
So I have a suggestion for whoever is presenting.
Yes, sir.
These questions are now considered standard. So rather than make a slide saying hematuria since 2 months, describe the hematuria in one line so that we don't waste time. So is that okay?
Yeah, absolutely. Well, that's how it should be.
Yes, we are not here to discuss hematuria history. You have to go on all over to the management. So, okay. So Vicky, remember that.
Yes, sir.
Go ahead.
History of presenting illness. Patient had hematuria since 2 months, gross intermittent episodes for total associated with clots and tissue bites, not requiring admission or blood transfusion, and the hematuria was painless, sir.
See, again, Vicky, here this not requiring admission blood transfusion is useless.
Okay.
Don't add it.
Okay.
Yeah.
And no history of pyuria. Next is no history of pyuria, sir, or no history of any storage or voiding symptoms, no history of fever or without chills, no history of abdominal or flank or back pain, no history of prior urological interventions, no history of significant weight loss, no history of bone pain, breathlessness, jaundice, and lower limb swelling or abdominal distension.
So you can, Harish,
Yes, sir.
you have to tell them when to move to the next slide.
Yes, sir. I would like to know
No history of
hyperthyroidism, no history of DNB.
Why are you bringing in thyroid here? Vicky?
the comorbidities, that's the reason I.
No, why don't you simply mention no comorbidities? Because if you mention no hyperthyroid, they will immediately ask you what is the connection between hematuria and thyroid.
Okay, sir.
Unless there is something related to the thyroid which you want to bring out, in which case don't play tricks, put it up front. And say he's going to have this problem and he's under treatment, not under treatment, whatever. Okay?
Okay, sir.
So Harish, any other history that you want?
Any abdominal lump I want to ask, if at all any history of abdominal lump or anything. It was only flank pain or abdominal pain only. If at all any history of any other abdominal lump, I would like.
Harish, again,
Yes, sir.
if it is not presented, don't unnecessarily ask for it. Because how many patients are likely to feel a lump and how many lesions which cause hematuria produce a lump which is palpable, what percentage? Very few.
Yes, sir.
Ask for things which are of importance to you, which will help you get to the diagnosis. Whether he has a lump or not, your diagnosis won't change.
Then I would like to know his personal history, sir, actually, whether he's any smoker and whether That
So no smoking there actually. He's not a smoker and no tobacco chewing or anything.
then I would like to know the examination findings. It's a 58-year.
Why is his history of diabetes important?
So diabetes predisposed to one is recurrent urinary tract infections, as well as other diabetic drugs such as pioglitazone may predispose to bladder carcinomas.
Can without cancer diabetes present with hematuria?
Yes, sir, with UTIs associated with urinary tract infection.
Any
Without
other cause?
UTI, without BPH, can it present with hematuria?
What are the conditions do diabetics suffer from?
Diabetic cystopathy, sir, and
Cystopathy.
diabetic cystitis.
Diabetic cystitis.
What happens in the kidney?
Kidneys, pyelonephritis, pyelitis, predisposed.
No,
You've not. You're going all around.
problem.
Papillary necrosis can present with hematuria.
Yes, sir.
We'll go on to the case back, but one quick question is, why is it only the papilla that necroses in a kidney? If you haven't thought of it, go back and read.
Yes, sir.
I think papillary necrosis is something you will come across. You should understand it. Okay, we'll come back to the case then. What you wanted examination.
Yes, sir.
Have we given a history of weight loss?
Yes, sir.
Yeah,
Okay.
there's no weight loss.
Okay, I understand. Okay.
General physical examination is essentially normal. So there is no ECOG 0 and other examinations. I would like to know the systemic examination, upper abdomen and external genital examination.
See, they're just saying no pallor. Are you happy with that?
So if pallor is present, then possibly we will think of anemia. Sir. And also,
Okay. Can there be any pathology in which pallor is absent but other signs might be present? Other general examination findings.
if there is a CKD, then probably pedal edema can also.
Yeah. So, Vivek, Vicky,
Yes,
you
sir.
have to put all that in.
Oh,
Don't
okay.
skip.
Okay.
Right, go on, please.
Harish, what do you want? You have to tell us. You examined him. The examination appears to be non-contributory.
Would like to know the abdominal findings, abdominal and as well as the rectal findings.
Okay.
Genital and rectal. Also is
Why are you bothered about suprapubic fullness here? Vicky?
Any
See, again, when you put down these symptoms, please focus on what you expect or anticipate reasonably. Okay, if a person has got difficulty in passing urine, lower urinary tract symptoms, suprapubic fullness has got some meaning. If somebody is presenting with hematuria, why do you want to put in suprapubic fullness?
Maybe no palpable renomegaly is more relevant here.
okay.
Okay, so Harish, the examination is still non-contributory.
Like to investigate the patients with urine routine, urine culture.
You have a working diagnosis, I think.
So there is, since it's only a gross hematuria, there's very differential diagnosis.
Harish, please speak louder.
Yes, sir. There may be since most commonly it will be a carcinoma of the lower urinary tract.
We are unable to hear you.
Carcinoma of the bladder, sir, and carcinoma of the upper tract are also possible. And the other thing is urinary tract infection. But there is no frequency, and dysuria is also not there. And they may be associated with the other differential diagnosis are vesical calculus with BPH, or BPH cystitis complicated with BPH, but there is no LUT set. Most probably it's a painless gross hematuria. I would like to consider carcinoma of the upper tract or lower tract in my first.
Other than hematuria, are there any markers of a malignant process?
No, sir.
So you have to have other eggs also in your basket.
But there's no LUTs. The prior LUTs is not there. There's no.
Sorry?
There is no prior LUTs.
Agreed. Therefore, when you say this is my differential diagnosis, you have to have other conditions, non-malignant conditions also.
Yes. Like.
Okay, you just can't say it is carcinoma, either upper tract, lower tract, whatever. You would put that up front if there was weight loss, for example, if there was a palpable mass, for example, if he was a smoker, for example, so on and so forth. Now, here is a person whose history is absolutely normal, in the sense he's got no contributory factors in history. He's had episodes of hematuria for the last 2 months and no weight loss, no fever, no weight loss. There is no pallor. So why should you only think of malignancy? What are the non-malignant conditions which can cause hematuria?
ADPKD, PUJO with a trivial trauma can also cause hematuria.
Where is the history of trauma? What nonsense are you talking?
PUJO.
PUJO, okay. See, we've discussed this. What are the other things? Run over the list. Doesn't matter whether you think it's important or not important. That we'll decide as we go along.
So, we've also discussed this earlier, Harish. When you're asked a broad question like this, you classify it in some way, no? You say that I would think of renal causes, then in the ureter, then in the bladder, then in the prostate. So if you classify like that, then probably it will be a smoother answer. Or you say I will rule out malignant causes, inflammatory causes, congenital causes, whatever, in some order.
Yes, sir.
Just to give you some idea, if you have somebody with painless hematuria, with clot, without clot, in your mind you figure, with clot, without clot, painless hematuria, you must say that these features would suggest that this patient has age, everything, has got malignancy. If he's got some smoke in history, you can throw that in and say, those are all punchlines which you can give it. If it is painful hematuria, then again your differential diagnosis will be related to some form of inflammatory process. And then you will keep your malignancy diagnosis low down. So as Manish and Prabhu were telling you, just work it out this way so that you are, in your mind, you're clear. And the examiner also knows that you're thinking in a logical fashion. By saying, I'll investigate, of course you will investigate the patient. That even the what by will tell you have to investigate. We have to be a little bit more scientific. Huh? So you work it out this way so that examiners knows, okay, this guy is going with a plan. He's not just shooting.
Okay, so for everybody, hematuria differentials is a huge list. Please go through it and you should be able to answer this question a little better. So what investigations do you want?
I would like to first create a urine routine, sir, along with that urine culture. And then...
You list out all the investigations you will ask for.
Then urine cytology. After that, CCT abdomen and pelvis. And blood investigations such as, if at all...
So your first investigation after urine analysis will be a CECT?
No, sir. Urine routine, urine culture, urine cytology, along with that blood investigations, routine blood investigation, CTs, complete blood count in terms of HB and all the other WBC platelets, and then serum creatinine, then CECTs.
What do you have against an ultrasound?
So ultrasound, since there is a differential diagnosis, is like maybe a stone disease, maybe this one investigation which can give is CECT abdominal tubes.
So since I've gotten into trouble in my exam because of saying CT scan directly in a patient suspected of a renal mass, I would say that unless there is no indication at all, go stepwise, ask for an ultrasound, then proceed for a CT. I know Dr. Ganesh has taught us many times that when needed, you just go and do a CT. In practical terms, that's okay, but at least I got into trouble in my exam because of that.
Yes, sir.
So given then,
Here there is albumin mild trace and there is a MCh. So RBC is greater than 100 and WBC is 10 to 50.
The values we can also read. The interpretation is what we would like from you.
Hematuria, sir.
There is hematuria. Okay.
would you qualify this as pyuria also?
When hematuria is there, 5 cannot 10 to 15 maybe associated with it.
Yeah, don't ignore it.
Yes, sir. HP is 13.6 and creatinine is 0.9. It's almost all are normal. That is.
Would you have asked for a PT with INR?
No, sir.
Okay, so not indicated.
I have a question related to this, related to the investigations, not directly relevant. What is the difference between blood urea and blood urea nitrogen? Vicky is presenting, so Vicky can tell us. Okay, look it up because if you're presenting, you should know.
Next.
Thanks.
Is that how a cytology is reported? Harish?
No, so urine cytology reported with the Paris classification. It's one is adequacy of the urine, and then
Adequacy of the urine,
amounts.
sediment. Urine is all right. There is enough urine there for them to spin it. It's the sediment that is more important. Unless there is something there, they said they cannot report. Then?
And then negative for urothelial carcinoma. The species of urothelial carcinoma.
Generally, you've seen cytology reports, isn't it? Supposing you were reporting or you were expecting a good report, what are the things you want to see in the report? Now, I have a suspicion this guy might just have caught some water and given for cytology.
Along with the dysplastic cells, there may be epithelial cells along with that.
Isn't it?
Yes, sir.
So you find a sediment, the sediment has got other cells, it might have degenerative cells, and if there are dysplastic or malignant cells, you'll find them also.
You read the description given by pathologists. There are two brands of physicians in this world who have excellent descriptions of stuff. One is dermatologists. They go to town about describing a lesion. And the second is pathologists. So we tend to read only the report. But read the whole report which is there, the micro report and how detailed they tell you. If you had read that, then you would be, this is obviously verbatim copied by the guy who was presenting. He just left out the details, just a negative for high-grade urothelial carcinoma. It also would mean that there may be low-grade malignancy. We don't know what is between the lines. It's very important to know what was the body of the report to indicate that, well, maybe there could have been a few dyskaryotic cells, there could have been some fewer, but in the eyes of the cytologist, he didn't think it was negative, it was positive for anything at all. But you as a clinician have got the hang of the patient. So you have to make a call, whether you want to repeat the cytology. You have to ask him, how many times was this done? We don't take one cytology report, we do 3 minimum, isn't it? So ask him, when was it done? What is the timing of this report? In the exam, when you start asking pointed questions like this, the examiner will immediately know what you're talking about. He will not ask you another question. He will just move to the next one. And when the examiner moves to the next question and walks out of the room, that's not good news. He asks you a question and stays there, that's good news. These are all, body language in this whole game.
So just one more point on cytology. Do you know how sensitive it is in which sort of malignancy?
In low grade, it is around 40%. So in high grade, it is around 50% sensitivity with the 3 samples.
In low grade, 40% is a very high number. It's somewhere around 10%. And in the highest grade also, I think it is some 56. Okay. So somebody says 80 to 90. I'm not so sure.
I think there's a difference between specificity and sensitivity in cytology. If it is specific in terms of high grade, that means if the cytologist says it is very sure. So it may be highly sensitive, but not specific. He may have a lot of description in between, but he's not very sure. But when he says it is malignancy, it is malignancy.
Okay, sir.
How do you send what are the instructions you give before sending the urine for urine cytology? Just start again here.
It's the first ambulatory voiding sample is comes early morning after first void.
So he collects urine at home and brings it over?
No, sir. It has to be immediately processed.
How much urine to collect?
Sir?
How much urine to be collected?
50 ml.
And if the patient has got active hematuria, what will we do?
Yes, hematuria decreases the sensitivity because since the RBCs are high, along with the malignancies, it may decrease the sensitivity of the test.
Okay.
Maybe all of you should look up the process for collection of urine specimen for cytology. The result of cytology will depend entirely on the collection process. It's not early morning, it's not late night, it's not overnight. It is 3 to 5 freshly voided samples. And we don't wait for 50 ml or 100 ml or whatever. As soon as the person can pass urine, the person passes urine. The lower the volume, the greater the yield. Remember that. Therefore, it is 3 to 5 freshly voided samples. In certain labs, the voiding is done into the preservative. In other labs, the preservative is added as soon as the specimen is collected.
Most of the labs would like you to do the cytology there in-house, not bring it from home or bring it from somewhere else. So they will ask you to do it there. Unfortunately, some labs also insist that it's the first morning because I think the technician, it's the receptionist there which gives the instructions in many situations. So we have to fight with them sometimes and say, no, you have to give it any time during the day. Okay.
Okay, go ahead.
ultrasound bladder where there's a 3.5 centimeter size heterogeneous mass lesion protruding from the posterior wall of the bladder with increased vascularity. Other upper tracts are normal.
Would you still insist on a CECT now?
Since tumor is greater than 3 centimeter, we can go for CCT.
What are the other indications in a suspected urothelial malignancy where before TURBT you will do a CACT?
If it's BUJ tumor, sir, and if any associated hydronephrosis is there, and if any suspected upper urothelial carcinoma is there.
So size and location, anything in the trigone, also you would do. If you had multiple tumors all over, probably you would also do. Okay?
Yes, sir.
Okay.
Next.
Vicky, we've also said you need to
name
patient's identity you have to remove when you present these slides.
okay.
Yes, Harish, those are all the films that we have. Can you describe the section that we are seeing now?
There is a homogeneous enhancing lesion in the posterior wall of the bladder with 3 cross 3 centimeter 3 cross 3 centimeter lesion with.
What is the outstanding characteristic of this lesion?
Enhancing.
The enhancement, yes, but what is the morphological characteristic? Outstanding morphological characteristic.
It's a single lesion, sir. Single
lesion in terms of numbers.
Yes.
Morphology.
It's look like a pedunculate. It's not a sessile one.
Can we go? There's one more film from the bladder. Can you show that, please?
2 varieties of
Papillary
tumor.
and
So
it's papillary.
that's what he wants to know, morphological picture. Is it papillary? Is it solid? If it is papillary, is it single? It is multiple. Solid, is it single? It is multiple. Pedunculate, sessile. Is the enhancement uniform? Is the enhancement not uniform? So, nothing.
And also, there's no enlarged lymph nodes.
Is that all that you want to say on this section?
Sir, there is no other. I would like to know other upper tracts also, sir. After that,
No.
On this section.
Anything else you want to tell?
On this section.
the bladder wall is uniform, sir. There is no.
No what?
There is no distortion of the bladder wall.
More than distortion, what would you expect or what are you looking for?
Any peripheral extensions, any
You're looking at local thickening
and
extravesical extension. Correct?
yes, sir.
Can you see fat? Sorry, sir.
Go ahead, man.
Fat plane is not maintained between the bowel and the bladder.
So on this section, you cannot identify the fat plane. Anything else now that we've gone outside the bladder?
Lymph nodes.
Yeah, where would you look for the lymph nodes here?
Very
Second for basic staff is request to call
Perivesical and hypogastric obturator. External
Where? What structures are guiding you?
along the external iliac arteries.
So along the vessels, you would look for it, and if there are any obvious mass nodes.
Where we look for the obturator nodes?
Near to the neck of the femur.
Neck of the femur.
No, not head of, near to the opposite of the.
So where is it?
It's not in this.
Yeah.
Not in this.
Yeah. So you.
Why is it called an obturator node? There must be some reason why it's called an obturator node. That gives you the clue about where you look for it.
Obturator vessels.
Obturator vessels or something more? So many sections assisted, no? They show you when you do the lymphatic dissection.
Obturator
But what is the structure which is there, man? One white structure which is going across there. It kicks like that. What is that structure? Yeah, man. You do a TRPT and suddenly the patient kicks. Yeah, but what is it due to?
Because of the obturator now.
No, man, the nerve is a constant figure there. At the operator artery, there are so many there. The accessories and the main operator. The main the nerve is constant all the time, isn't it? So it is in that fossa. So if you can imagine a CT scan, where exactly that fossa is, you look for it there. There exactly it is. And you'll see it there in that fossa. If it is not, if the nodes are there. You look there, then you go up.
The obturator internus muscle is your guide, because that is something which can be seen prominently. Next to that is a nerve, and in that neighborhood you look to see whether there are any lymph nodes.
Yes, sir.
Okay, what do you want to do? Anything more? Assume the upper tracts are normal, since he hasn't shown it to us.
In this cut section and also in the other sections, you see what is outside the tumor.
Bowel gas.
Yeah, that's a sigmoid probably. So you should be very careful. If you perforate, you are into the colon.
Yeah, so you want any further investigations, or would you like to treat this patient?
No, sir, I would like to I'm looking for the TUR bit.
Yeah, we all tend to forget the chest X-ray nowadays. I think you should do a chest X-ray and then proceed. Okay.
I'd like to know the histopathology.
Any other intraoperative findings that you would like to know?
Or if you're doing it, would you like to look for some other things intraoperatively?
Yes, the number of any associated carcinoma in situ is present.
You won't know what it is. Any associated abnormalities of the bladder mucosa. Anything else you want to know? As a preliminary to cystoscopy, as a preliminary to resection.
Number of tumors which are single tumors. Number of tumors.
Yeah, that will make out at endoscopy.
You want to see, apart from abnormality in the mucosa, anything else more specific in the mucosa that you want to see around the tumor, adjacent to the tumor?
Vascularization.
Anything
Any
else?
associated carcinoma in situ, which is
That you've already said. Anything else? We've discussed this many times as to what are the findings at endoscopy in a patient with a bladder tumor. It's a very favorite question in the exam.
bladder neck.
Bladder neck. See, when you look at a bladder tumor, you know that either this is likely to be invasive or likely to be non-invasive. With that in view, you look at the endoscopic findings and then say, oh, this looks a little bit funny, this looks a little bit difficult, there's something else here happening. So when you look at those findings, you want to be a little bit more aggressive with whatever you want to do with the lesion. Kind of lymphatic obstruction in the bladder.
Bullous lesion.
Yeah, bullous. You will see edema around. I want to see in bladder tumor sometimes edema around, nasty looking things. Into that there will be a lot of neovascularization. Somewhere else there will be some areas of erythematous changes, maybe just erythema or just maybe CIS, velvety lesions. Huh? So you have to see all these features. So if you have a patient who's got these features, your diagnosis is likely to be this is an invasive bladder tumor, and therefore your resection would definitely include something to prove your point of invasiveness. You wouldn't just take a biopsy from the top. Okay, so this particular report, biopsy of the growth with deep muscle tissue taken. I presume they have done a TURBT.
Yes.
Otherwise, you can't take the top biopsy of the growth. What is it? So, as a discerning person, what do you mean by that biopsy of the growth? You must ask this.
Along with deep muscle there.
How can you take a biopsy with the deep muscle? You have to resect it, then only get deep to that node. So you want to know. TURBT, so was it completely resected with that? Complete, you didn't listen to that resection that they talked, uro-oncology talk? Complete resection.
Yes.
You have to, is it 3.5 centimeter growth? You have to completely resect it first. Then only you talk about what else you want to do. No?
So Harish, in addition to all this, whether the tumor is bimanually palpable or not, and whether the efflux from both ureteric orifices is normal or not, and about the growth itself in the CT itself, sir had asked you whether it's papillary or sessile. It's not mentioned here. So you would ask that question.
Yes, sir.
So the other things that you might notice is necrosis in the tumor. You might find calcifications in the surface of the tumor and so on. You find them, you note them also because they've got their own connotation.
Yes, sir.
Why do we do a bimanual examination, Harish?
To know the extent, sir. If the mass is palpable, then maybe it may be a T3B disease.
So what? What if the mass is palpable? See, extent anyway, you're doing an endoscopy, which will tell you how big the mass is.
It has poor progress.
Sorry?
The resection is not complete, sir, but after the...
Will you do the bimanual before or after the resection?
Before and after the resection.
You'll do both. Okay, why do you do it before?
Before to assess the initial assessments.
Correct. What do you want to assess? What is it that you want to assess through the bimanual examination?
The mass is palpable and whether it's mobile.
The mass will not be palpable, Harish. The next time you do, you check out. Most masses are not palpable. But something else can be palpable. Which is your interest. Say presence of induration, thickening, focal thickening of the bladder induration, which you may not be able to make out endoscopically.
Yes, sir.
That is what we are palpating for in a bimanual examination. Okay?
Yes, sir.
So the mass is a fleshy mass. You won't be able to palpate it through the abdominal wall. But what you can palpate is areas of induration. You can also, if it's a laterally placed tumor, see whether it is close to the pelvic wall, attached to it, fixed to it, or whether it is free. And it's the same thing that we look for after resection, because prior to resection, if we found that there was induration, there was a focal area of thickening, we want to check whether that's gone away, which means the resection is complete.
And Vicky, it should say that superficial and deep tissue are sent separately for histopathology.
Okay.
Okay, what do you want now, Harish?
Point for all residents wait for the exam. If Dr. Manish is your examiner, you will say bimanual examination. Otherwise, you will fail. Have you noticed? Every class is insisting only on the bimanual examination. So if you don't say the exam is the examiner, you'll be trouble. What do you say, Manish?
If Dr. Venkatesh is the examiner and they say bimanual, they might fail.
Thank you. Put the side first.
Okay. So now, what do you want, Harish?
I would like to know the histopathology reports. Whether
I don't know whether this is how the wiki has put the report or this is how the report is, but there is a certain order in which these tissues are reported. It's good to stick to that order and remember, even in the exam, it will stand you in good stead if you follow that.
And Vicky, I don't think it is superficial muscle. It is that the superficial TURBT chips resected area shows papillary urothelial carcinoma. So Harish, are you in agreement with this report? Is there any discrepancy here?
so deep muscles are also involved by the tumor. So if deep muscles are involved, there has to be a high grade one, not a low grade malignancy.
Yeah, so low grade and muscle invasive don't go together. I think it should be superficial tissue and muscle, not deep muscle. So
even if it is low grade, lamella propria invasion, lymphovascular space absent, so all those, you have to look at all the features. Low grade tumor with involvement of the muscle. Unless this is where it is important to actually, for the endoscopic surgeon, to label the specimen correctly, because the pathologist does not know. He is getting one lump of tissue. So you have to be sure, because ultimately you will have to decide what treatment that is to be given. So if you look at this as a report, it doesn't make sense. So obviously there was something either in the sampling that was done or sent. So you take the first tumor, send it, label it. Then you take the second and you label it. You give them 100 samples. You say, I want all of them sampled. One favorite question that is asked in the exam is, how do the pathologists actually report these TURP chips for TURP and TURP? So find out that. Suddenly they will surprise you. You send 50 grams of prostatic chips. How do they report? What do they do with this? Favorite question asked by some examiners. Think about it.
Incidentally, there is a protocol. Okay, it's not random. There is a protocol that they follow to sample prostate resection tissue.
The best defense,
what do you want?
the best defense is to say, this is how our pathologist does it. So you ring up Lakshminam Bharti and ask him, sir, how do you report your prostatic chips? What do you do with all this finish? Then he'll explain to you what we do. His technique may be slightly different to somebody else's technique, but this is your best defense, and this is what our pathologist does.
So we'll assume that Vicky has altered the report a bit, but this is all that we have with muscle invasion. Now what do you want to do?
With muscle invasion, with no nodal disease, I would like to go for a radical cystectomy.
Hang on. Now, be very careful. Be very, very careful when you answer a question like this. you've seen a 3.5 centimeter lesion hanging around in the bladder on the posterior wall. You got a 50-year-old guy, isn't he 50 years old?
Yes, sir.
58.
50, a reasonably young fellow. Okay. Now, when a question like this is asked in management, you have to say, hey, if I had this tumor, what would I actually want? You got a biopsy report which is dubious, low grade something, and something else involved, nothing else is there. The rest of the CT scan looks good. So what is the examiner looking for here? You must be able to read his mind. He knows that radical cystectomy is what you're going to say and what most people might do, but he wants to know something different.
Again, I could read you are ready to confirm the findings. Since it's only
What
a low
will be your treatment strategy in a patient like this?
already
That means you know what's happening in the world currently.
neoadjuvant kind of.
What is the goal? Do you think you can cure him? Do you think you can palliate him? Do you think you want to prevent recurrence? Do you think you want to prevent metastasis? Do you think you want to do as little as possible to keep him happy for the rest of his life? So what is the goal of treatment? What is the philosophy underlying your decision making?
Would the patient prefer a radical or would he like to have his bladder?
CT is showing no nodal disease and only minimal perivascular.
No, that's not the question. When you tell the patient you've got this, would the patient prefer to retain his bladder or would the patient prefer to do without the bladder?
Retain the bladder.
Retain the bladder, correct. So you have to make a beginning from there. What are you going to tell him why you want to remove the bladder? The discussion begins from there. Why do you want to remove the bladder? Can't you do anything else? Is there some way? So many new things have come in. Okay, you remove the bladder. Am I going to be free from the disease? Do I need anything before surgery? Do I need anything after surgery? If you remove the bladder, how will I pass urine?
Giving you suggestions. Now you've got to work on it. Don't interject with an answer at the moment, but he's giving you leads as to how you would look at this patient, which means what are the other modalities of treatment of a lesion of this nature in a bladder in a young man. While we understand that radical cystectomy is what people might advise, the flip side of the coin.
That's something. If patient is, since it's almost around less than partial.
Not if the patient. You look at the entire scenario. You have on one side a patient with a tumor like this, where 1, 2, 3, 4 tumors are there. One side is hydronephrosis, invasive tumor. Match is over. Nobody is going to question you as to whether you're going to do cystectomy at all or not, provided the patient is fine. But when you have a lesion like this, one solitary lesion, can completely resect it, sitting in a very favorable location in the posterior wall of the bladder, 3 swipes and the whole tumor is off, deep muscle is involved, everything is fine, you resected the mass completely. The rest of the bladder is absolutely pristine, there is no hydronephrosis, there is no nodal disease. Is there any other way of treating such a patient? Some years ago, Dr. Venkatesh Alsi presented a whole class on this in this seminar. He also made this discussion at one of the South Zone meetings or CMEs and all that. Huh? What is the treatment?
Radiotherapy and
So what is it called?
multimodal.
Trimodal therapy. Use the right words. The examiner is looking for this answer. He wants to know whether you have thought of the possibility, because right now there is a lot of data on trimodal therapy and there is a big push to actually offer this as primary treatment for patients with good results. Okay, while we understand, yes, cystectomy, you want to do neobladder, you want to do this, oh, fine, okay. As Mohan said, A man with his own bladder, the ability to pass urine, good bladder capacity. So you've got a lot of features here which would indicate that this man is ideally suited for trimodal therapy.
If he goes to oncology center, the first thing they'll ask is review the slide. Because it's not matching the low grade and
All
so
that. So I will review the slide, re-resect. If the patient comes to you, if he's gone to the primary fellow, that is his call. But if he comes to you for second opinion, you must be very careful. The second opinion patients are dangerous guys, generally speaking. They are testing the waters.
Yeah, Harish, let us say this is what the patient came to you with from another hospital. And he says, sir, this is what they did, this is what they've seen. I've come to you for a second opinion. What will you do?
It's a review of the pathology slides. If at all,
Yeah, he's come with everything. I mean, maybe your friend who's done the resection has sent the patient to you saying, I want a second opinion, please meet him. Called you up and said, boss, will you look at this and advise?
Mohan, I recently saw a visiting card of a urologist who's written his name and he's put in underneath that second opinion urologist. Yeah, there's a visiting card there. I see it.
Rather honest of him.
Okay, so Harish, you would ask for the slides and blocks and send it for a second opinion.
yes.
It comes back as this. Now we've said one option is trimodality therapy, the other is radical cystectomy. Now suppose I'm giving radical cystectomy here, how do I proceed?
We'd like to counsel the patients which type of diversion, mostly ileal conduit. After this one, we have to counsel for him regarding the ileal conduit stoma and
Okay.
He'll tell you, I've heard that it's still possible to pass urine via naturalis. Well, you're telling me something about some new thing. I've heard that even after removal of the bladder, people can pass urine through the urethra.
then neobladder.
Therefore, you have to discuss the whole gamut with him. Correct?
Yes, sir.
You can't say I'll do ileal conduit. The next urologist will say, this fellow doesn't know to operate, that's why he's doing a conduit. There are other surgeries that can be done, you'll pass urine normally.
Would you consider him for chemotherapy before you offer radical cystectomy?
Neoadjuvant chemotherapy has a 5% survival when compared to radical cystectomy alone. So it can supplement neoadjuvant and then take it for radical cystectomy.
Is it recommended? Let's assume this is a T2 tumor.
Yes, sir.
Pardon me?
For T3 and T4, we can downstage the disease and then take T2, but only overall survival.
Neoadjuvant chemotherapy is recommended, sir. There is a overall survival advantage is 5 to 6%. And
What is the age? What stage?
T2 to T4A, sir.
Okay. So there is a recommendation for neoadjuvant chemotherapy. Whether you give it or not is different, but the recommendation is T2 to 4 should have neoadjuvant.
Can we do an orthopedic gallbladder for it?
Sir?
Your bladder reconstruction.
If urethra is not, there is no any malignancy in the urethra and bladder neck, then orthopedic neobladder can be considered. And if it's filling for the
So since the patient is young here and the tumor is in the posterior wall,
Yes,
If
sir.
the margin is negative, then definitely orthotopic neobladder is an option for him.
Location of the tumor is also important when you are looking at trimodality therapy. Whether it is amenable to a partial cystectomy or not is important.
Yes.
Okay, so Vicky, have you treated this patient?
No, sir. A patient has not come back.
Second okay, he's gone for second opinion.
What is the opinion given anyway? He hasn't come back yet.
Vicky, we want to know what your opinion is. What have you planned for him?
So we have planned only for radical cystectomy.
Okay. Now, if he's come to you, we've decided no neoadjuvant chemotherapy. Harish, for you, we've decided no neoadjuvant chemotherapy. He's come to you. Surgery is not due tomorrow. You have a few days available with you. What will you do?
Or he says operate as quickly as possible. What are you going to be telling him? Can you do it the same evening, next day? Or do you want to do a few other things?
Since his hemoglobin and all is 13, sir.
Sorry, we can't hear you.
He has a good hemoglobin, PNS and as well as the counseling regarding the stoma.
You know, all that you will do in any case.
Yes, sir.
Dr. Manish's question is, you have a little time on hand. He says, can I get it done after the 1st of next month? Because by then I'll have got my salary. You've got another 15, 20 days on your hand.
No, sir. Since it's already a muscle invasive, if it is delayed, then the survival comes from oral.
Okay, so yeah, we will try and do it as soon as possible, but not the next day. But is there anything that will help him with early recovery after surgery?
Early recovery after surgery.
Topic in itself.
Yes.
Early
ERAS.
question. He's asking what will help him. Early recovery after surgery. That's the expansion of.
Do you know any components of the ERAS protocol?
No. Ayyo. How can you say you don't know, man? 1 month before the exam, but you don't know any component of ERAS protocol? Whole world is talking about it.
Okay, make a guess, man. What do you think is involved?
Diagnostic workers and
No, he's already posted for second. Yeah, I know, do it. So
Okay, so Harish, go back and read about ERAS protocol.
yes,
I think if you're practical also, it could be asked. So should we present the protocol?
Yes.
Next time, Manish, maybe?
Yes, not today, sir. Next time. Okay, sir.
Yeah, we will.
Okay, sir.
Who will present? Volunteers? I think one of the exam going chaps should present, Manish.
Somebody is here, sir. We'll tell you. Oh, somebody will have gone. He was finishing on 8th.
Okay. No, if he's still interested, let him do it.
It doesn't seem interested, sir.
Doesn't seem
We'll ask-
interested.
We'll ask Harsha to do it.
Yeah. Okay.
ERAS protocol.
Yep.
One thing that is never given in ERAS protocol. What is it? they prefer to avoid.
They'll tell us next week.
Anyway, there are basically two components here. One is the intraoperative and the other is in the post-operative. Both of them, in synchronous fashion, work towards improving a outcome and discharge from the hospital quickly. So both those components have to be addressed in the protocol. If the patient is to be started, then pre-operative, whatever you want to do, and because that also is important. Remember, one of the biggest problems with radical cystectomy is delay in gut motility. Large space created as a result of all this dissection. So the consequences of both these are involved in this ERAS protocol and how you want to make sure it. That's all it is.
Shall we call it today?
Yes, sir. Thank you.
Thank you all. We'll catch up next week. Have a good week.